so we have no disclosures. So as we heard this morning, the Kawashima operation is used for palliation of patients with single ventricular anomalies with interrupted inferior vena cava. However, we've seen examples of development of pulmonary arteriovenous malformations and leading to cyanosis. That eventually requires incorporation of the hepatic blood flow back to the pulmonary circulation to provide the hepatic factor essential for regression of those fistulas. However, there are institutional policies that vary between one institution and another with regards to how to deal with that. Some would refer those patients early, however, some would wait for a long time until they refer the patients for hepatic vein incorporation. And there have been several studies that Dr. Barron mentioned this morning from Melbourne, from Indiana, and from Boston that showed incomplete and unpredictable regression of those AV malformations, and suggesting that maybe those patients should be referred earlier for a hepatic vein incorporation. The other challenge in those patients is the streaming of flow directing the hepatic blood to one lung versus another, the frequent presence of bilateral SVCs, because many of those have left atrial isomerism, and pulmonary artery stenosis complicate that further. So I'm going to talk about that a little bit more as well. So this is an example of, in fact, a patient of mine from 10 years ago who had AV malformations as documented here, but came in with clubbing and severe cyanosis, about 60% saturation on room air. So we thought we just need to go and do the hepatic venous incorporation with the extracardiac type, Fontaine type conduit, and he was severely cyanotic post-operatively, even worse than before. And we went to the cath thinking maybe there is some technical issue. And you can see we could not see any blood flow going to the other lung, only one lung. And you can see the malformation. And eventually, when they occluded the left pulmonary artery, they were only able to show that the right pulmonary artery actually is unobstructed. However, all the flow is going to one lung versus the other. We struggled with this patient. We put him on vena-venous ECMO, hoping for the collaterals to regress in a timely fashion. However, he didn't do well. So we aimed in this study to examine outcomes of patients who have undergone Kawashima to report early and late results following hepatic vein incorporation. At our institution, we tend to refer them early before the development of significant collaterals, and also to outline finally our current institutional policy to deal with the challenging issues on this patient population. So we had 22 patients in about 10 years. The average age at time of the Kawashima was 265 days. However, we've done it as early as almost 5 months. Majority had left atrial isomerism, and about 2/3 had bilateral SVC. The majority had prior first-stage palliation, including Norwood in the majority, followed by BT shunt and PA band. So what you can see is that, as we all know, they go home with a pretty good saturation, with the average of 87% saturation at time of the Kawashima. So that definitely is an effective way to increase their saturation. However, when we looked at our Kawashima patients, there was zero mortality. And the events after the Kawashima, about 18 underwent hepatic venous incorporation. One actually was supposed to have that. However, the surgeon had sternal re-entry injury and abandoned the surgery. And unfortunately, this patient died, and he's the only mortality in this series. And the other three of them have accessory pulmonary blood flow, so they're doing fine, and one of them is scheduled for hepatic vein incorporation by me next month. So the hepatic vein incorporation, we had 18. 2 had their surgery at different institutions, but 16 underwent their incorporation at our institution with a median interval of 3.4 years and age of 4 years. And these are the types of surgery that were performed. But what I was trying to show you, so they obviously, although they left the hospital with very good stats, quite a few of them, despite that we're referring them early to surgery, have been cyanotic early on. And in fact, 4 of them were on home oxygen or in the hospital on oxygen prior to their hepatic vein incorporation. And when we do the surgery, a bunch of them still cyanotic, and in fact, 5 of them needed to go home on home oxygen. However, what we found differently, you can see here, as compared to other series, that the vast majority, within few months of those patients, all of them are off oxygen. The saturation is on average about 95%, and only a couple of patients are in the 88 range. So this is different from other published reports, and we think this is probably likely because of 2 effects. One of them is early referral, and the other one is what I'm going to talk about in a minute. And as I mentioned, only 1 late death at time for the sternal reentry. So our current institutional policy is to do MRI vascular mapping and do virtual surgery to examine different options, and then we send them to Georgia Tech, where they do computational flow dynamics and tell us what is the best option, and we do our surgery based on that optimal model. So what we try to do is just first we obviously do the MRI acquisition, and then what we do, we try to do the vessel segmentation. There are several ways of doing it. This is the bouncing ball. This is the easiest way. What we end up having is a 3D reconstruction of the vascular anatomy of the patient. So usually you might need to have different goes at it. So usually they do it, they go back, do more imaging, and then eventually they are able to derive this 3D model. And they can do, in fact, some in vivo examination of the blood flow. And this is an example of a patient who had a previous extracardiac or hepatic vein incorporation at different institutions that was not working well, similar to the patient that I showed you an angiogram of earlier on. So what we do after that, we do a virtual surgery, and this is the old way of doing it. We used to have to go to Georgia Tech. However, now we have that in 2 computers in our office. This is my colleague Kirk Cantor working on it, and I'm gonna scroll quickly, but basically we have the anatomy. We can have the options to insert a conduit, insert the heart, look at different options. So I'm showing you here, we insert the conduit, we change the shape, we change the location, we change the size, we can even do a Y graft. But anyway, we derive different options. So this is what the surgeon would experiment and send to Georgia Tech. So this is one example where we have done extracardiac conduit. This is one example where we modeled Y graft. Here we did H graft between the hepatic veins and the inferior vena cava, and here we try to channel hepatic veins all the way to the innominate veins. So we designed those 4 options, and we send them to Georgia Tech. What they do there is the computational flow dynamics. They can actually do computational flow dynamics. They can even create a model or do dye streaming. But what they provide to us is they tell us how is the flow going to be in each option. So this is the extracardiac with an offset. You can see that the hepatic flow distribution is not even. This is the H graft, and you can see that it's much better. This is the option of having a Y graft, and this is the option of going to the innominate vein, and it's pretty good. So what else they can do? They give us power loss for all those models. They can also give us the hepatic vein distribution for all those models. So in this patient, they recommended that the best option is to do an H graft, and you can see after we did it here, 16 millimeter conduit between the hepatic veins and the azygous vein, and this is the angiogram, and the patient actually went home with a saturation of 93%. So in conclusion, timely referral for hepatic vein incorporation after Kawashima is recommended because the majority of those patients form AV malformations. A number of those will require O2 early after hepatic vein incorporation. However, with this early referral strategy, the majority have normal saturation on follow-up, which is improvement from historic studies. MRI and computational flow dynamics are useful preoperative adjuncts to address the challenge of differential flow streaming. Thank you.